Hello, and thank you so much for joining us today for the webinar Early Detection of Caries Lesions with X-ray-free near-infrared transillumination and Appropriate Treatment. It is a great pleasure to introduce to you Dr. Kuenisch, whose aim during this presentation will be to report on the potential of the method, his own research results, and previous clinical experiences with the near-infrared transillumination. Furthermore, he will compare the method to established techniques and typical treatment strategies for different caries stages. We'd like to thank Dr. Kuenisch for being with us today and DT Study Club for making this lecture possible. Please take note of any questions and comments you have during the lecture, as they will be addressed by Dr. Kuenisch at the end of the presentation. Without any further delay, please help me welcome the expert himself, Dr. Kuenisch.
So, hello everybody. I hope that everybody can hear me. I will introduce myself first. My name is Kuenisch and I'm working in the Department of Pediatric Dentistry at the Ludwig-Maximilians University in Munich. And today it's my task to share my experiences with you regarding the near-infrared light transillumination. And you will see the majority of my presentation is dedicated to our clinical experiences, and secondly I will talk shortly about our study results, and you will see this in the next slide, what is our agenda. Finally I'm talking about the practical considerations and will draw our experiences from diagnostics to treatment. I hope that anybody can agree with this little agenda, and I don't want to lose any time and would like to start to give you in short information about the background, where we are in caries detection and diagnostics. And first of all, I would like to introduce you to the idea of the caries iceberg, which was introduced several years ago by Nigel Pitts, where he illustrated the disease of caries, where we can understand the disease with the peak of the iceberg, which we can see day by day, and this is the cavity. And over the last decades in many countries, and maybe it's today the same, that in many countries the decay, the hole in the tooth is the diagnostic cutoff to choose operative treatment, or maybe in some cases also non-operative treatment. But the problem is below. This is the majority of this is the burden of caries, and this can be understood today as non-cavitated caries lesion, which we can find on all tooth surfaces. We will find these non-cavitated caries lesions in pits and fissures. We will see them on proximal sides as well as on smooth surfaces. Furthermore, if we are going one step deeper into the sea, then we can detect the first visible signs, the first visible stages of caries, maybe a small discoloration in pits and fissures, or such lesions which are more or less inactive in some elder patients. This image is coming from a 12-year-old which have learned to brush and clean the teeth, and you see that the non-cavitated caries lesion is not located anymore in the at the gingival margin, which is more or less caries or the high-risk area on such teeth. This means that we underestimate the caries burden if we are using visual examination alone, and this is illustrated by this X-rays. If we have a closer look on this X-ray, then we can. I try to show you. I have the opportunity to use a pointer, but I can't see this so far. But I will tell you without this pointer. You see the large cavities in the primary molars, and as well as the beginning caries lesions on the mesial surfaces of the first permanent molars. And for that reason, it must be stated that we have a problem on proximal sides. And I can tell you here we need additional diagnostic tools, and this is maybe the link for our today's webinar. And the caries is going on also in the permanent dentition. We have the same problem, maybe with much more important consequences, that these are the permanent teeth which will be there for the next 6, 7, or maybe 8 decades. And caries starts early. Caries starts in the first or second decade of life, and it means that at this age the caries starts for the next maybe 50, 60 or 70 years. And this illustrates from this pair of bite wings illustrates the problem in a 35-year-old patient, where we can see also on the proximal sides beginning dentine caries lesions, which were unable to detect by visual means. And this is an interesting observation from our daily clinical practice, where we are not seeing any more primary caries in the first or second decade of life. It is shifted to older populations, to elderlies, into the third and fourth decade of life. Nevertheless, it must be stated that if we are talking about methods for caries detection and diagnostic, that the clinical checkup, that the visual examination will be the first choice in daily clinical practice. But it has to be mentioned that there are two prerequisites. First of all, it is of importance to clean the teeth so that we can see the caries lesion. Please compare the left image in comparison to the middle one. The plaque is covering the lesion completely, and we cannot see the lesion itself. And another prerequisite for caries diagnostics and detection is to dry the teeth, and for that reason we are using the airflow from the dental unit to flow away the saliva and to have a dry surface which can be evaluated by visual means. And it must be stated, Kim Ekstrand said some years ago that there's a good evidence today that we can do that clinically. And I can tell you from the last week workshop from the EAPD in Brussels that this statement was reaffirmed, and there's definitely good sufficient evidence to do this clinically. But of course there are limitations. Please think of the bite wing radiographs I have shown to you just before in the primary and permanent dentition, and for that reason we need additional diagnostic tools, and the method of second choice until today is the bite wing radiograph, and there are a lot of advantages. We can detect proximal enamel and dentine caries lesion. We can see the occlusal dentine caries lesions. We have the possibility to see secondary caries or residual caries beneath restorations. And what is an important tool today, is to have a staging that we can measure or assess the caries extension in relation to the enamel dentine junction and the dental pulp. And in my eyes, it is an important tool to monitor proximal sites, but there's a small disadvantage that we are using X-rays, which is in some cases not really favorable for the patients. Nevertheless, there are some more limitations, especially think of my daily work, that I have to work with a lot of children, and these children are in several cases uncooperative and do not cooperate having a good bite wing radiograph. Furthermore, we are seeing overlappings. Please think of pregnant women where we have the problem not to perform any X-rays. And it should be also mentioned the group of disabled patients or those with special needs where we have problems to perform bite wing radiographs. And again, there's definitely a need for alternative methods. And if we are going back for the last 15 years or 20 years, there was a huge interest in such alternative methods, and the majority of these techniques were photo-optical methods, where it started maybe with a photo technology, maybe Diagnostic, QLF was very much promoted within the last years, and all of them are using light of different wavelengths to illuminate the tooth, and to detect and diagnose caries. But it must be stated from my work over the years that a lot of methods did not fulfill our requirements we need for the daily dental practice. But it changed a little bit, or I changed my opinion a little bit some years ago, where I had the near-infrared light transillumination device, a Diagnostic, for the first time in my hands, and I was really fascinated about the potential of this method, and I would like to share my experiences within the next minutes with you. Maybe before we are going to the clinics, I will give you a short introduction about the mode of function. This device can be understood as further development of the digital fiber optical transillumination, but there are some small changes, but also important changes. And first of all, the wavelengths changed, and it changed from visible light to near-infrared light. And the background is that longer wavelengths, near-infrared light has a longer wavelengths, scatter less, and therefore can penetrate objects more deeply. And so it's possible to transilluminate tooth material as well, and to make caries lesions visible. And the second modification is that, hopefully it works now with the pointer, yes, and that we have another change. Normally, or the majority of diagnostic methods illuminating the tooth from the occlusal perspective, or maybe from the proximal areas, and then an important change is that the light path starts now near the apical region. The special for the camera was designed a special tip where the light windows are now in the gingiva area, and the light is going via the gingiva, via the bone into the root, and the light path, which is of interest, is going into the direction to the coronal part. And in case that there's a caries lesion, the light is absorbed, scattered mostly, and finally reduced, so that less light can be detected by the CCD sensor in comparison to the healthy tissue, where the majority of light is going through without any absorption or scattering. This is more or less the mode of function for this device. How are looking images? You see in the upper part second quadrant from young permanent dentition, and below you see the images in the near-infrared light. We are seeing a small discoloration on the fissure. We are seeing very clearly the enamel, which is more translucent in comparison to the dentine, and the dentine appears ever darker in comparison to the enamel. And this is more or less the typical situation we can find regularly in daily dental practice. I would tell you at this point a small drawback, or an important drawback, which we should evolve, that there's it is impossible so far to visualize with this technique the dental pulp, and this means we can detect a caries lesion. Look here, this is an enamel caries which reached the enamel dentine junction and penetrated the enamel dentine junction into dentine, and I will tell you later that such appearances are associated with a deep caries lesion. You can see the same lesion on the bindwing radiographs on the right side of the slide. But what we cannot see is a dental pulp, which we can clearly see here in this case on the bindwing radiograph. Yeah, and for that reason, if we would like to stage the caries, especially in dentine, which is in my eyes of daily clinic of importance for the daily dental practice, then we need bindwing radiographs, and yeah, and that's important to know if we are using this device. There are some further points which are of importance to acquire good images. First of all, we have to play a little bit with the region of interest, and you see this here. If we have the region of interest in the middle of the image, then we can see this demineralization here. And if this image is going out of the center, out of the middle of this image, we are losing the presence of the Caries lesion so far. And this means we have to use the camera, maybe a little bit careful, and should play with the handpiece a little bit so that we can see the demineralization if someone is present. Another point is we have to bring the camera directly above the teeth from the occlusal perspective. In the left image, the focus, the distance from the occlusal surface in relation to the camera is quite fine. On the right side, it must be clearly stated that we can see the lesion, but this image is definitely out of focus, and it has to be modified, and it depends from us to use the camera appropriately. Another experience which is more or less well known to all of them who are working with this camera is that it is of importance to switch off the chair light, the light of the dental chair. And you see this from this example. In the left image, the operation light was switched on. On the left side, it was switched off. And it means we can see here the demineralization, which is not detectable on the same tooth with operation light. And for that reason, it is recommended to switch off the operation light. In the next slide, I have collected some enamel caries lesions for all of you to get an impression what is the strength of this method. And I deeply believe that the strength is lying on the detection of the early enamel caries process, and you can see this throughout all of these images where we have different types and different kind of caries lesions which are located definitely in the enamel, and maybe in these last three cases, in some areas it reached maybe slightly the enamel-dentine junction. We talked throughout the last years a lot about a possible graduation system, and we developed some scores which could be of clinical interest. And first of all, the stage 0, which is representing a healthy proximal or a healthy tooth, is that there are no demineralizations visible in the enamel as well as no one in the dentine. The next slide is showing us beginning caries lesion, a beginning demineralization in enamel. You see this triangular spot here, and it must be stated that this is the first step of demineralization. And you can imagine that such small changes in enamel are definitely not visible in bite-wing radiographs. And further on, if we are following the caries, it goes, of course, deeper. If it's not arrested so far, then we are seeing an established enamel caries, and it goes on. In the direction of the enamel-dentine junction. It becomes deeper, it becomes broader, and the size is enlarged, and such lesions are definitely present. And we can see such lesions in most of the cases also on the bite-wing radiographs. And furthermore, we can detect those lesions which reached the enamel-dentine junction, which is illustrated in this image. But what we can see definitely in enamel that is mostly more difficult to assess in the dentine, as the early process in dentine is in most of the cases not visualized with this technique. We can assume that as larger the enamel-dentine junction is reached, is demineralized, we are taking the next step. You see here that the demineralization reaches a long distance along the enamel-dentine junction, and it means that the enamel-dentine junction is reached, it's infiltrated, is perforated, and we don't know, as there is no definitely clinical sign of an existing dentine caries lesion, but we can assume, and we had seen this from our study results, that all of the cases which were treated were linked with a dentine caries lesion. And I had shown you such case just before. If we are seeing those images, it means that it's a very deep caries lesion, and here we definitely need urgent dental treatment so that the pulp is not further compromised. Some more clinical images. Here again, we have on the near-infrared light image extensive shadow in enamel as well as in dentine, and the corresponding cavity is linked with a deep caries lesion, which was definitely beneath the dental pulp, and these cases are definitely challenging to treat. An interesting case, unfortunately, the first image is not visualized here, and I can tell you that this case was definitely a sound fissure system where no clinical sign of a discoloration was present. But the clinician, as clinician, we were able to detect such shadow here on the bite-ring radiograph. And as I had seen this, I took the near-infrared light technology, and I was really surprised to see such a dark shadow here in this area. And after opening of the dentine caries lesion, we found a caries process which reached half the way in direction to the dental pulp. Another case from the occlusal perspective. Here we have a small cavity. This is definitely visible. What is interesting to see is the shadow around where we have a less translucent dentine, and it gives us an intention how far progressed is this caries lesion on the occlusal side. Of course, we are able to detect dental restorations. Maybe here we have a composite restoration on the proximal side. This is also visible in near-infrared light. And another case where the composite restoration appears a little bit darker. From our experience, it must be stated that the composite material consisted of different filler materials with different light properties, and this causes different impressions and different brightness on the near-infrared light image. But I can tell you most of the cases, most of the composite materials which I obviously used here in Germany, having such an impression. Like here it is a grayish appearance, what is normally quite good detectable if we are looking on the margins of the available margins. In some cases it is necessary to have a second look, a closer look on these sides to be sure that this is a restoration or something else. Amalgam restorations maybe are not light translucent, and it means that they are appearing dark in comparison to composite materials. Oops. Ceramic restorations are also visible, and they have the same impression like composite materials, and again the major characteristics which we can see on the near-infrared light image is the cavity margin. It is also possible to illuminate teeth which are treated by an orthodontist. It is possible due to the light illumination in the apical region that the light path is different in comparison to the traditional way of usage where the light is coupled in the coronal part of the tooth. I have some case reports for you. This is an 18-year-old patient, and you see more or less a healthy dentition, and we performed some x-rays, and unfortunately this patient, or the x-ray was not so good on the right side in comparison to the left side, and so I used the near-infrared light technology to investigate the proximal sides. We see the video. I hope that it works around the globe to all of you. And I will start with the first quadrant. And interestingly, we detected demineralization on the tooth 1-4 on the distal side. You can see this very clearly here with this dark shadow, with this less translucent enamel, with this less translucent area. The lesion is located here. So let's go on. The tooth 2-5 is fine. What I'm looking for, oops, I hope that it works. Oh, yeah. Maybe. Okay, thank you for this advice. Okay, we are starting again. We are seeing here the proximal lesion, and what I'm looking for is, especially for proximal caries detection, that I would like to see if there's something present in the proximal space. Maybe I don't want to stop the video again so that we can see this video smoothly. And look here, they are detected on the tooth 2-6 distal dark shadow, and as I detected this, I re-investigated. You can see here a small crack which is visible on the near-infrared light image, and of course there is a lesion present until the enamel dentine junction. And these are the teeth from the lower arc, and you see the screening does not detect any demineralization so far, and this means the near-infrared light in my hands is a screening tool, or becomes a screening tool, to investigate the patient on a very fast way and to see if there's a need for additional diagnostic methods. And I can tell you, and this is one of the conclusions of my presentation today, that the near-infrared light became the second opinion in my eyes for caries detection and diagnostics. Okay, let's go on. In the next slide, we have a 7-year-old patient, and those who are familiar with children are seeing these white spot lesions nearby the gingiva, which is illustrating definitely a risk for this, caries risk for this patient, and it means here we need additional diagnostic tools to investigate the proximal sides. In the next slide, you see the occlusal perspective. The patient, this was from the first appearance, had a cavity in the lower arc, and an interesting finding was these enlarged pits on the palatal sides, which were configured by nature in this way. But of course, if I'm seeing a cavity at this age in such patients, there's definitely an urgent need for additional diagnostic tools, and it means that we need to investigate this child furthermore. And again, I made a video from the near-infrared light transillumination, and the aim is to detect any further problems, to detect any further lesions, and to see the severity of the Caries process. So I start the video. Oh, it's squeezed a little bit. I don't know what's the reason. We tested it just before. Maybe I interrupted, and I asked the technician to start it again for us. You see, we are live, and some failures can happen, and I hope that we can restart the video so that we have the full size available for us. Maybe I go back and I go. Unfortunately, it doesn't work. So very good. You see, okay, I will start it again, and I will stop it on the interesting and maybe most important sites. What is important to note is to detect such demineralization, such dark shadows, which is in the primary dentition is sometimes quite difficult. And it means if I detect such cases, then it means that I would like to perform bite-wing radiographs to get a staging of these Caries lesions. Of course, unfortunately, the video is missed now. I wanted to show you. There is it again. I wanted to show you the cavity again, which is coming on the end of the video. Here we can see we can't see it so very good in comparison to the regular video, to the regular format. The other proximal space in the second and third quadrant were Caries free. Just a minute. Now we have here the tooth with the cavity, which was clearly visible on the or by the visual examination. So, okay, now we are taking the next slide, and we can take away the video window. And if we are collecting our clinical findings from the visual examination, from the near-infrared light examination, which we cannot see here, and the bite-wing radiograph, there's a good overlap. In clinics, we don't see such Caries process, but we can detect it from the bite-wing radiograph, as well as from the near-infrared light transillumination, and the cavity was also seen on or with all methods. And again, this is a finding from the clinics only, and we have to consider this and should use a sealant or a minimal preventive resin restoration. Okay, another case for screening where it was impossible to perform an X-ray or a bite-wing radiograph, and for me it's important to see if there are any further problems in these children, and for that reason the DiagnoCam is a good opportunity to use. Here we are seeing more or less nothing in this child. Again, here there's nothing, and this is a distal surface which is where we don't see or don't find any Caries lesion. Important is the proximal space between the tooth 4 and 5, and again in all quadrant these areas were free of any early signs of demineralization, and for that reason we avoided we did not perform and did not prescribe any bite-wing radiographs to this child. The story is a little bit different for the next case, and this is also the last one with the video, where this little boy had some more Caries lesions. Oops. I stopped the video, and unfortunately it is... No, it's better. No, it's not better. But we can see it. Here is a dental restoration. Here's a composite restoration, and around the composite restoration we see a dark shadow. And this is a very clear sign that a secondary caries is present, and the same on the mesial side of the tooth 5, where we have to the vestibular side caries present as well, and this means we have to reinvestigate and should reconsider restoration for both teeth. Let's going on with the video. You see this here maybe much better in comparison to the frozen image just before. This is a second quadrant. Here we are seeing some restorations, and the distal surface of the second primary molar was free of caries, and again here are the restorations. And furthermore, in the fourth quadrant there's a caries lesion further present, and it means here we have the need for staging these lesions, and we perform bite-wing radiographs in this child. Okay. As I mentioned just before, we have in our clinical department a lot of special need patients, and in a lot of them it was impossible so far to perform any types of radiographs. And as we got some years before the Diagnostic system, we are able to diagnose, especially in severe affected patients. Let's talk about the study results, and I think it's of great importance to talk about the science behind this the system. And I will brief you very shortly about the aim and what we did, and will show you the results soon. And we aimed with our clinical study to determine the diagnostic accuracy of different diagnostic methods for proximal dentine caries detection. And we used for answering our questions and clinical diagnostic study, we included around of 80 patients, and finally 127 proximal caries lesions were investigated. For diagnostic purposes, we used the visual examination. We used the Diagnostic pen, which was earlier designed for proximal caries detection, and we used the Diagnostic device beside the reference standard, the bite-wing radiograph. Finally, it was very interesting to see that Diagnostic performed more or less equally for dentine caries detection in comparison to the digital radiography. We found high asset values, which is an important measure for evaluating diagnostic tools. And this was an interesting finding that both methods performed quite similar. But again, it must be stated that we were unable to include enamel caries lesions as it is definitely impossible to validate them in a clinical study today. And for that reason, the dentine caries detection was the main focus of this investigation. And another important information is that we didn't performed any overtreatment in this study. It means that we did not opened a lesion which was located in enamel only. I will give you some more information regarding the usage or the different content of information from lesions like that in comparison to those which are clearly visible in dentine. I think we can differentiate these two stages where we have an indirect hint that the dentine caries lesion is present. In these cases where we are seeing a dark shadow, it is very clear that we have dentine involvement. If we measure the lesion depth or the caries extension into dentine, we were able to calculate percentages from the enamel dentine junction, which is 0.0, which is 0% caries involvement, until 100% caries extension, which means the caries process reached the pulp. And these two pillars can be understood as D3 caries lesion. These lesions are located in the outer quarter of the dentine. Here we reach the inner half of the dentine, and here we're going one step deeper into D4, and those lesions are nearby the pulp. And you see from the distribution, the grayish areas are those cases with no direct visibility of the dentine caries process. And it means that those lesions are located more or less beneath to the enamel dentine junction, but the number of lesions decreased, and as deeper the caries process was. And the opposite finding we found for those lesions which are clearly visible with the shadow. Some few cases were located nearby the enamel dentine junction, and the number increased of those lesions in direction to the pulp. And for that reason we can conclude those lesions are located most probably in the outer part of the dentine. Those lesions are located most probably in the inner part of the dentine. Let's talk finally about treatment decisions and what we are doing with these diagnostic findings today. Unfortunately, this slide is not animated, and it should bring attention to the ongoing discussion in cardiology, in restorative dentistry, about cut-offs for treatment decision. And I can tell you now from conferences, from workshops, from a lot of discussions with dental practitioners that we are more or less at a turning point, what we should do in dental practice. But the problem is that we don't have so much information as we wanted to need to make exact information today. What is consented that cavitation is definitely an indicator for operative dentistry, and furthermore, if the lesion is going deeper and deeper in direction to the pulp, we have to protect the biological tissue of the pulp, and it means a dental restoration would be really fine. But where the cutoff is, if we would like to stage the caries. D1 and D2 lesions, it is definitely not the part for restorative dentistry. But if we are going deeper and deeper, then the necessity for dental restoration will increase, definitely. And all of these decisions will depend further from the caries risk, from the caries activity of the lesion, and furthermore, the patient wants to have a special treatment, and we need a consensus process with the patients today and should develop a diagnostic plan and further a treatment plan for the patient. And within the last slides, I would like to pay some attention to the staging and what we can do most probably in relation to these staging. We are definitely happy today that we have a lot of healthy patients which do not need any additional diagnostic methods maybe, and we can monitor them and we'll see what is going on, and if the risk is changing, what we can see clearly visible with the presence of non-cavitated caries lesions on smooth surfaces maybe, then we should bring additional diagnostic methods to the attention of these patients. But again, it is also a well-known understanding of our profession that we should introduce all of our patients to a tooth-friendly diet, to optimize their daily oral hygiene, to use fluoride products, to prevent the onset of any further caries lesions. And if we are looking at here standing D1 and D2, it means that we are also able to use powerful preventive technologies to arrest these caries lesions. And again, tooth-friendly diet, optimal oral hygiene, and fluorides are working definitely fine. But there are some new technologies on the European market. I don't know what is the global issue for the so-called self-assembling peptides. Maybe they will have maybe the potential to arrest such early caries lesions, and this is maybe an excellent link between early caries detection and diagnostics on an enamel caries level, and to link these new technologies, these minimal invasive technologies together. And furthermore, and this is a technology which is available for 5 years, the caries infiltration technique. And again, here I see the potential to infiltrate such kind of lesions and to arrest these lesions. And that what we know from clinical studies from the last years is that we are successful in 75–80% of our cases to arrest the lesions. But it means on the other side, that we have to monitor these lesions, that we have to observe if we are successful with our preventive measures, if we are finding a stagnation of these caries lesions, or if the caries process is going on. And of course, deep caries lesions, what we are missing here is the binding radiograph and the near-infrared light image, which is showing us for this case the deep caries lesion from the diagnostic perspective. Okay, I hope that I summarized most of the clinical experiences we've got over the last 5 years, as long we are working with this technology. And I can tell you from our experiences from the last years that the sequence of diagnostic methods changed a little bit. Of course, the visual examination, the clinical examination, will be the first choice to examine a patient. But you see that the near-infrared light comes into the game as screening technique, and I can use it in a lot of patients, in a lot of young patients. Maybe this is my special perspective as pediatric dentist, that I have the opportunity to screen the teeth much better in comparison to have a bite wing radiograph, which is less frequently accepted by the young patients. And furthermore, if I'm seeing lesions like that, then I prescribe a bite-wing radiograph, and it means then I have the staging of the caries process, and then we are seeing the deepness, the grade of progression for these caries lesions. And with these words, I thank you very much for your attention, and we have definitely the time to answering some questions. You will have the opportunity to write some questions to the technician, and I will get it, and so I will try to answer all your points. Thank you very much for coming. Thank you very much for your attention, and yeah, thank you. Yes, of course, here we've got some questions, and maybe some of you or maybe all of you can see it. The question is Diagnocam an alternative for bite wings? There's yes and no. We can detect on the enamel caries level these lesions very early and very sensitive with the Diagnocam. Again, what is the missing piece with the Diagnocam is to see the dental pulp and to have a good staging. For that reason, we will need bite-wing radiographs to diagnose the caries process. And as I had shown to you, it is in my eyes an excellent tool for screening the patients and reduce the number of bite-wing radiographs, which is across Europe definitely an issue in pediatric and dental practices as well, where the patients are asking us, is it necessary to have bite wings? How can we reduce bite-wing radiographs? Do we really need the X-rays? And this is a strong point for this X-ray-free technology. Hope that I fully answered this question for you. We've got some more. Question. There's a question regarding the costs. Here in Europe, in Central Europe, in Germany, the dentists have to pay 5,000 euro for this equipment. It depends a little bit from the dealer. It depends a little bit from taxes and so on. But 4,000 to 5,000 euro have to be planned. The question is, can Diagnocam detect root caries? I think there's no. As I'm working in children, I'm not so experienced in elderly patients, but from my understanding of the technology, it must be stated that the root caries is located deeper or much deeper below the coronal part of the crown. And I think so far that there are some limitations, but Frank, you can assist me a little bit if I'm wrong. I've got the agreement that this is a correct answer for you. Another question is about recurrent caries under restoration. I had shown to you the case with recurrent caries, secondary caries, or whatever it is named. Beneath to the oral or vestibular side, it can be detected easily, as you had seen this in the video. Under the restoration, it might be much more difficult, as the restoration above will hinder the light path a little bit and will reduce the light, and so it's definitely difficult to detect. But in those cases where we have or where I detected secondary caries, it was frequently not really visible, and the near-infrared light helped me to detect this. Thank you for your question.
Thank you very much, Dr. Kuenisch, for sharing your lecture and your insightful information with us. We'd also like to thank DT Study Club for making this online course possible. And thank you, our wonderful audience, for your interest and participation. The CE quiz is now available online on the course page, and completing it will allow you to earn your ADA CERP CE credits. The recording will be posted online within the next 48 hours. You will receive an email notification with the link to the recording. Further questions for Dr. Kuenisch may be submitted directly on the website on the courses page under the Ask the Expert tab. So please go ahead and submit your questions, and Dr. Kuenisch will be sure to get back to you as soon as possible. Please be sure to visit the DT Study Club educational platform, www.dtstudyclub.com, and keep an eye out for a growing schedule of online courses. Thank you again to all, take care, and goodbye.